Greetings. My name is Karen Ledee Lewis, and I will serve as facilitator for this portion of today's program. I would like to welcome our distinguished group of guest physicians. To the viewers, it is our goal to address all submitted questions while prayerfully enhancing your information bank regarding COVID-19 disease and the vaccines that have become available. Please note that today's discussion is based in truth, wrapped in compassion, while encompassing statistically sound data. We believe that it is critical that you have the necessary information to formulate your individual choice as to whether you will choose to receive the COVID-19 vaccine. COVID-19 disease is a public health crisis, and we value your seat at the table, as we should contribute to curtailing the spread of this horrific disease. There is no time like the present to advocate for diversity, equity, and inclusion in the management of this disease. Your questions and input are of great importance. Now, moving forward, I would like to define and differentiate 5 terms that may be mentioned during this town hall meeting as to optimize understanding. Firstly, though SARS-CoV-2 and COVID-19 disease are used interchangeably, they are not the same. SARS-CoV-2 is the strain of the coronavirus that causes COVID-19 disease. Secondly, morbidity as it relates to medicine. It is an unhealthy state of being which can relate to the health of a larger population, as in the proportion of sickness or of a specific disease in a geographical locality. Thirdly, comorbidity. In medicine, it is the presence of one or more additional conditions, often co-occurring with a primary condition. Fourth, mortality. It refers to the state or condition of being subject to death. In other words, as with today's topic, the mortality rate reveals the number of individuals who have died from COVID-19 disease. And last, efficacy, the ability to produce a desired or intended result. And to the pastors, you offered some wonderful, wonderful questions. And what I'd like to do is to dive into a couple of those, and then we'll move on with the program that we have set. Let's say, Dr. Carter, would you be so please share information about COVID-19 and the demographics and what have you?
Great question, and thank you for allowing me to be here. With the Pfizer trial, there was approximately 9.8% of their study population that was African American, with 81% of that being Caucasian. And similarly, with the Mrna trial, there were 9.7% of their patient populations that were actually Black as well, with 79% being Caucasian and 25% being Hispanic. So I want to make sure that I address the question of what are the demographics of the patients that were studied. And then also within the Mrna trial, approximately 25% of their study panel were healthcare workers. And so that's another demographic that was asked about earlier regarding how are we going to have to protect our healthcare workers. Well, thankfully, many of them were included in the trial, so that will give us data based on that information as well.
Thank you so
much. And I would like to add that the question as to whether there is actual COVID-19 disease or the virus within the vaccine, briefly I will say, by receiving the vaccine, you are not given a shot of the disease. So the answer is no. Dr. Brooks, welcome. The first question is for you, sir. Globally, there have been approximately 1.9 million individuals that have died from COVID-19 disease as of this morning. And the source for this information is the COVID-19 tracker through Johns Hopkins University, City of Systems Science and Engineering. Dr. Brooks, will you please elaborate on the infection rates for COVID-19 disease in the United States and within the Black community? And secondly, what is the mortality rate for Blacks in America?
So first of all, a thank you to Pastor McGinsey and my colleague, Dr. Fobbs, for having me on this. Appreciate what we've been discussing. I'm sorry I'm not live there, but I am alive, and I appreciate that from the spirituality that is presented. African Americans have 2.6 times the case rate of whites in America. We have 4.7 times hospitalization rate and 2.1 times mortality. And thank you for defining these terms. So to put that in context with other racial and ethnic groups, we have the highest mortality rate. Next highest would be American Indian Alaska Native at 1.4 times higher than whites, a Latino 1.1 times higher. Now, of note also, Latinos have about the same rate of cases, 2.8 times versus blacks 2.6. Hospitalization, we're 4.7 times versus 4.6, but we die twice as much as all the others, pretty much. So that's really, really relevant. There's been a lot of discussion as to why African Americans die at a higher rate, and I'm sure there will be discussion by the other physicians, has been briefly touched on. Ultimately, underlying conditions, social determinants of health, and racism. So I will stop there. I will just say that another question was asked about African Americans. I'm immediate past president of the National Medical Association. We met with Moderna, Pfizer, and AstraZeneca, the makers of the vaccines, and we have formally endorsed the two that are presently available. So as it relates to the African Americans and involvement with knowledge about the vaccine and awareness, we've done it on a scientific level, and as representatives of the 50,000 African American physicians in the United States, we formally endorsed the use of both vaccines.
Thank you so much. So what I'm hearing you say is that African Americans are dying twice, 2 times the rate of any other ethnicity in America. Is that correct?
1.4 times is Native Indian Alaska. So that's just, if you think about it, that's a very small proportion of our population.
Yes.
So based on the whole population, yes, dying twice as much.
Dying.
And that's the worst outcome, obviously, that one can have.
Wow.
But do note, even if you get it, hospitalization rate 4.6 times whites, sequelae that come after being hospitalized with this can last for years.
Yes. Now, the numbers are real, and I think we have to keep that at the forefront. We mustn't become complacent. We're speaking in numbers, but numbers equate to people and persons. So when we say 1.9 million, that's 1.9 million individuals. We have to personalize that, as we discussed earlier about how this is affecting our healthcare providers, our families, our communities, etc. Those are people. Now, Dr. Fobbs, historically, Black individuals have not taken advantage of the vaccines. Only 45% of Black individuals receive the influenza or the flu vaccine yearly. Yet, many individuals die from complications associated with having influenza. My question, will you please shed light on the historical experiences of Black individuals who suffered medical maltreatment that has led to the distrust of the medical community, which may lead to an aversion of Black individuals choosing to receive the COVID-19 vaccine?
Thank you, Karen. That's a wonderful question. It is a question which I will definitely try to answer briefly. I have a couple of friends. One is Michael Bird, and the other is Linda Clayton. They wrote 2 volumes, about 3 inches thick each, to answer this question. So we're not going to try to cover it in that depth. The point they made that we need to take away when it comes to African Americans in America and trust in the system, it goes back to slavery. During slavery, there was a incentive to take care of Black people a little because they wanted them to be available to work well. After the abolition of slavery, that incentive went away. And frankly, the health status of African Americans, despite freedom of a degree, continue to languish. There was an establishment of health care for black people, mostly by black people on a second tier level that was what would be considered separate and unequal. That separate and unequal status probably has continued to a degree up to today. There has been much improvement. But it has not been forgotten. It's already been stated very well by Pastor McGinsey, how we go back and looking at this to the Tuskegee study. But before that, there was the unequal treatment in Jim Crow. Today, we have studies as recently as the last few years that still show that African Americans who have the same status, both economically, educationally, they take the same showers, put on the same clothes, they can go see the same doctors who are not black doctors, who will treat them differently, who will diagnose them differently and care for them differently from someone who is white of the exact same profile. And that's just over the past few years. So this can go back to slavery and come right back up to the present time. So there's a problem, and that problem still exists. So when black people say they're not comfortable, they're not enthusiastic about seeking certain medical care, vaccinations, and otherwise, they have a good reason for that historically and presently, and we know it. Now, what makes it even more complicated is that if you have a very mixed population of people you're talking to, and I do in my office, and what I see, frankly, is that white patients and Latino patients are not a whole lot better. So we have a big problem because, we have this incredible pressure and this incredible lid on the enthusiasm of black people, and a similar problem amongst a lot of other folks. And this includes, shockingly to me, even health professionals. So there's a problem, and I think that we're doing a good job, or we're trying to do a good job of trying to dispel the myths to help break through that problem. Dr. Brooks just did that when he talked about the origins and the certification and the oversight of this vaccine, which is substantial. The point was mentioned that this vaccine does not have any live virus. So people who worry about getting the disease from vaccines need to not worry and understand that. So we're trying to make breakthroughs, and I think a lot is being done to help that. But we know why, and we know why we need to be here today and doing things like this and more to encourage people to go ahead and understand that this is a safe and desirable vaccine, that the culture is better. It's not what we want it to be, it's just better. And they should move forward with this because it's going to help survive so we can move on and do some other things.
Yes.
Okay.
Yes. And I think historically we're not here to deny anything that has happened in the past, but I think it's important, as Dr. Fobbs said, that we be present in what's happening right now and seeing what we can do to make changes right now for all people involved, and particularly the black community. We know there has been a history of abuse and exploitation and experimentation on black individuals. We don't deny that. Dr. Eckerton, every county in California is assigned a tier based on its rate of new COVID-19 cases and positivity. The responsibilities of those in hospital management must be unimaginably challenging, frustrating, and exhausting. Management must equip a hospital with staffing, space for patients, personal protective equipment, while making daily adjustments to deliver care to patients across the continuum, all patients across the continuum. Dr. Eckerton, as a chief medical officer, what has been the impact of this pandemic in the hospital setting locally, and for anyone doubting that this is a serious public health issue, what would you like to say?
Well, first of all, Karen, to you and Pastor Dr. McGinsey, I wanted to say what a blessing it is to have a forum like this to discuss this issue. Knowledge is power, but knowledge is only as powerful as the ability to get it out to the people who need it. And I am so humbled to be a part of a forum like this that can get that information out to your congregations, to your public, because the Black church, as always, has been at the forefront of that in our community. So thank you so much for this opportunity. Now, to answer your question, for us, this pandemic has caused us to look at how we deliver care in the pandemic scenario. We have had to reorganize the flow of patients within our hospital. This has been done in almost every hospital in the United States that's dealing with COVID patients. We have been fortunate enough in our hospital to have the ability to convert portions of the hospital with regards to the airflow, because these patients need to be cared for in a negative air environment, so that we can develop COVID zones to take care of COVID patients in a safe and correctly isolated environment, while still maintaining zones in the hospital for patients who don't have COVID, because as you know, COVID's not the only disease that's out there right now that we have to deal with. We've had to be very mindful of the way that we use the personal protective equipment, that we are doing that in a way that is appropriate, thoughtful, that we're not misusing it, because the burn rate, as we tend to discuss, is higher now than it is in traditional times when we're treating traditional diseases that would normally be seen. Unfortunately, as part of our having to take precautions to keep people safe, we can't have visitors in the hospital the way we used to. So we've had to restrict our visitor policies. That's hard on families. We've relied on televisits, FaceTime, Zoom, in order to allow families to be able to visit their loved ones. And we've increased the use of telemedicine in order to do appropriate screening and protect patients who need medical care or medical evaluation but may not have COVID, so that we are only asking them to come out if it's indeed indicated for them to do so. Because we don't want anyone who needs medical care to stay away from the hospital because they fear getting COVID. We've noticed in the first wave of the pandemic that indeed did happen. So you have people with chest pain who would normally go to the ER, stay at home, and then they are subject to a significant cardiac event. We are doing this, and in most hospitals, I would say this would be the case, in an incident command format. That's a FEMA-styled mechanism of setting up a command structure within the hospital to deal with disasters. And we're doing that so that we have 24/7 ability to look at our situation as it evolves and to be quick and agile in the way that we approach this. And to answer the second part of your question, for anyone doubting whether or not this is a serious public health issue, on Friday we passed 21 million cases in the United States. And I would venture to say that by the time we start next week, we're gonna have passed 22 million cases. That's staggering. And if you look at the numbers that Dr. Brooks gave earlier, then that means a disproportionate number of people of color, Black folks in particular, are going to be affected by that. This is no joke. And it's likely, even with the advent of the vaccine, to get worse before it gets better, because it'll take a little while to get enough people vaccinated and enough people who have antibodies as a result of having had the disease to develop the type of herd immunity that'll be necessary to crowd out any future infections so that we can return to some semblance of normal.
Wow, thank you so much for that. Thank you so very much for that. So some of the words that were key: reorganize, convert, develop COVID zones, restructuring, televisits, telemedicine, patients not going to the hospital when they have chest pain or asthma or these things that we are already affected by. We're not going to the hospital. So that means people are dying at home when they could go to the hospital and receive care, but they're frightened. And we understand that people are scared, and it makes sense that you're scared. We understand that. But just to piggyback on that, if you have an issue, please seek care. Dr. Carter, thank you for answering that previous question that the pastors posed. There seems to be confusion as to when an individual should be tested after experiencing a known exposure. Now, who should be tested and when should they be tested after being exposed to an individual that has known COVID disease versus someone who has belief that they have been exposed?
So there are a couple different categories of folks who should be getting tested. And the first category are those who are symptomatic. Symptomatic being coughing and fever and chills, diarrhea, muscle pain, things like that. And the second category of folks are those who have been exposed to a known positive COVID person. You were in the room with that person or around that person less than 6 feet, greater than 15 minutes duration of time. And then the third category of folks who definitely should be tested are those who have been in settings where there are more than 10 people, we call that crowd or social gathering, for that same amount of time, greater than 15 minutes, less than 6 feet of distance. And so each of those three categories should get tested. Specifically, those who are symptomatic are at highest risk, but those who have possible exposure based on their social setting and those who have known exposures should also get tested.
And I'd like if you or Dr. Brooks can chime in. We know you've just told us who should be tested, but when should they be tested? Should it be the next day after? Should they wait 3 or 4 days to allow the virus to build up so that it can be seen on the PCR?
I can comment on that.
Thank you, Dr. Brooks.
So in my health center, where this is an acute problem at present, we're generally testing people 5 days after exposure. The CDC says that the average time to convert to positive is 5 to 7 days. Range is 2 to 14 days. The other thing is definition of exposure. The definition of exposure from the CDC is being 6 feet or less in contact with someone that is suspected or confirmed for 15 minutes or more. Not very clear whether or not if both people are masked, that you follow that. But for right now, we are. So just casually passing by someone who is positive is not considered a true exposure. I am a little more cautious. If both people were unmasked, then I'm very suspicious.
Okay.
Be specific, approximately 5 days after exposure, because if you do it before that, then they may not have converted. And if you wait too long after that and you find out they're positive, they may have been spreading it to other people for days and days.
Yes, thank you for that. I had patients where I work coming in day 1, day 2, day 3, and I was explaining exactly what you're saying. And believe it or not, some of the patients were upset, but it's the science, and I thank you for that clarification. Dr. Wiley, COVID-19 disease comes with a plethora of symptoms: new loss of taste and smell, cough, shortness of breath, difficulty breathing, fever, chills, muscle pain, and sore throat. As a hospitalist, Dr. Wiley, will you provide a glimpse into what hospitalization for individuals with COVID-19 disease entails? And why are the symptoms of COVID-19 why are they deadly?
Well, Karen, thank you, and Dr. McGinsey for allowing me to be here and discuss this issue. It's very important. It is devastating our community and our hospitals and the economics of this country. So basically, this virus is unlike anything we've ever seen. We've never seen this before. So they have similar characteristics of the flu, but it's much, much more deadly, basically. It ranges from being asymptomatic to being fatal. So when people come in, what brings them into the hospital is usually they cannot breathe. That's the #1 chief complaint, shortness of breath. And that's because this virus can cause a very deadly type of viral pneumonia as opposed to bacterial pneumonia. So the first thing that we do when somebody comes into the hospital is we get their oxygen saturation, the level of oxygenation in their body. And what qualifies for admission is if it's under a certain level. And basically the treatment for this is that we start with an antibacterial, it's an antibiotic. We use steroids to quell the inflammation of this viral pneumonia. And then we use a medication that's an antiviral. It helps to hopefully clear the virus faster. So that's kind of the first level of treatment for COVID pneumonia. For people who are what we call hypoxic, have low oxygen saturations. If that fails, and it does fail, that's when people get more sick, they end up intubated in the ICU. There is something called convalescent plasma, which is the plasma of an individual who's recovered from COVID. Their plasma, their body has produced antibodies that we can infuse into these extremely sick patients to hopefully, again, help clear the virus faster. So people who haven't responded to kind of the first tier treatments, we use the convalescent plasma. After that, we start accelerating our treatment program, our treatment plan, more aggressive antibiotics, more aggressive steroids. And hopefully they will recover. Number one, COVID is so deadly is because it causes a viral pneumonia, which is very aggressive and can destroy lung tissue, making it hard to breathe and keep the oxygen levels at a degree where people can recover. And then number two, it causes a phenomenon called thromboembolism. It causes blood clots to develop very easily, very quickly. So I've seen patients present with strokes. They did not come in with shortness of breath or fevers, chills, diarrhea, some of the more common symptoms. They came in because of a stroke, or they came in because of pulmonary embolism. And then we test them, and their COVID comes back positive, and basically this virus potentiates blood clot formation. And so anticoagulants are part of the treatment as well, routinely for COVID patients. So this is a disease that we really have not seen before. It's a new disease. We're still learning about it, but it's very, very serious. It can be very deadly, and it has destroyed patients' lives, and it will kill them if they present too late. At a certain point in time, some of these treatments will not even work because you've presented too late. The virus is already out of control.
And you had mentioned earlier that a part of the treatment for viral pneumonia is giving an antiviral medication. Would you please be very clear that that antiviral medication is not it's not what we do, and it has nothing to do with the vaccine?
No, it has nothing to do with vaccine. It's an antiviral medication that like you would use to treat viral illness. And
one last question. There was a lot of variables there, but the time frame from arriving to the emergency room to potentially being put on a ventilator could be very short?
Very short, yes. It can happen overnight. It can happen 2 days later. That's what we do in the hospital. We monitor these people. Some people can come in and they may only need 1 or 2 liters of oxygen. The next day, they may need 5 or 6 liters. And then if you see them deteriorating, then that's problematic, and that's why we escalate the treatment plan, become more aggressive.
You know, and I think you raised some, thank you for that. I have a better vision of what this is about, and it's horrific. And I would say, if nothing else, this is not a time to be lackadaisical about COVID-19 and potentially receiving the vaccine once it becomes available to those that choose to receive it. Dr. Eckerton, you had something you wanted to add?
Yes, Karen. I wanted to add a couple of points for the audience. One of the unique things, the unique thing about COVID-19 infections is that in the severe cases, the deadly cases, the virus isn't what kills or what causes that. It's the intense inflammatory response that we refer to as the cytokine storm. That's what is so hard for patients to deal with, which is why one of the things that doctors may do at the start of a decline in a patient is to start a steroid like dexamethasone or methylprednisolone, because that will help to kind of stem that inflammatory response. The other thing is, as was correctly pointed out, we're learning about this disease as we go. And there are different presentations. In the first wave of this pandemic, there was a study out of Great Britain where there were 6 different presentations of COVID-19 infections that were detailed, from a very mild presentation to the more common presentation of cough, fever, fatigue, shortness of breath, low oxygen saturation. And so there are many different ways that a patient can present. So we have to be vigilant in that regard. So it's something that we should not take lightly.
Thank you so much for that. So to reiterate, what I'm hearing is that as patients struggle for their lives, family members are struggling to make sense of it all. Healthcare providers are shouldering great responsibility and are engaged to the limits while caring for patients with COVID-19 disease. Though they are all struggling for different reasons, they are physically and mentally exhausted, and we must keep them in prayer. Dr. Brooks, this next question is jam-packed. Currently, there are 2 COVID-19 vaccines that are available. We'll be discussing primarily Pfizer and the Mrna Vaccines. Currently, there are 2 COVID-19 vaccines that are available and have been administered to thousands of individuals in the United States. These vaccines seem to have been created quickly, leading to concerns about their safety profile and their efficacy. Now, here's the question. Please provide information regarding the Mrna and Pfizer vaccines, safety profile, effectiveness, and are the vaccines similar, and who should receive them, and is there anyone that should not receive them? Thank you, sir.
Okay, thank you. So, first of all, the vaccine safety profile. They are both safe. The side effects that were seen were generally mild, redness, local redness, swelling, and pain at the injection site. Systemic fever, malaise, headache, some nausea, diarrhea. There have been 29 cases, I want to say, of a serious adverse reaction in terms of an allergic reaction. That's with about 2 million doses given. So that's about the average. You get anaphylactic or serious allergic reactions with all vaccines. Generally, the average is 1 to 2 per million, and that's about where we are. They are both effective, as I said. Mrna seems to be a little more effective after the first dose. They're both 94 to 95% overall effective. I would recommend that if you have access, you get vaccinated from whichever one you have access to. I believe there was another question in there that I didn't answer. So
yes.
Which one didn't address?
So you were saying that individuals should strongly consider receiving the vaccine, no matter which vaccine it is. But is there anyone that should not receive the vaccine?
Should not. So those that have had serious allergic reaction to a prior vaccine from prior COVID vaccine, which means you might have gotten the first one and then had a bad reaction, a serious adverse reaction, like an anaphylactic, allergic reaction that can be fatal. Or if you've had that kind of reaction to any component of the vaccine, the main one people are looking at is called PEG, Polyethylene Glycol. That's used to clear your gut when you have use it when you clear your gut to have a colonoscopy. If you have allergies like to food, pollen, seasonal allergic allergies, that is not a contraindication. you have underlying conditions like asthma. If you have severe asthma, then it would be recommended likely to get the vaccine, but get it in a controlled environment. If there are any questions you as a person personally have regarding this, you would consult your physician. But I would say 99.9% of the population can get the vaccine without any significant concern. And just one thing I'll add is that approximately 10% of the trial participants for both vaccines were African American, and the response of African Americans to both vaccines was identical or in line with the overall response. In fact, in one of the two vaccines, I honestly forget which, African Americans were 100% responsive, or it showed 100% efficacy. So we don't have to worry about that as it relates to our community.
That's good news. Thank you for that. Dr. Fobbs, I have a question. Black infant mortality rates. You know, Black infants are 3 to 4 times more likely to die before their first birthday than white babies. Maternal mortality rates in Black women died at a rate of 2.5 times more often than white women. I have a question. Should pregnant women receive the vaccine?
Well, thanks for that question, Karen. The slam dunk answer is yes, they should receive the vaccine. But I want to expand on that a little bit, because the initial research and studies on these vaccines, which I also want to emphasize, was not the rushed emergency overnight affair that some political talking heads might have indicated. This vaccine technology, which is fairly new and novel, is about 15 years or more in the making, and it just so happened that we were blessed that it was coming to fruition about the time of COVID-19. So this is not an overnight affair. This is a well-developed, well-tested technology. And that technology and this vaccine was tested extensively in the usual animal models during pregnancy, all phases of pregnancy, and there was not any problem shown anywhere at any time. Other similar vaccines, similar to this, coronavirus vaccines, have not shown a problem during pregnancy. So this is one of the, I won't say few, but one of the vaccines that has really a greater stamp of safety and authenticity to go ahead and take it during any phase of pregnancy compared to any other vaccine is actually greater for the most part, and should serve as a reassurance to people. Because we typically consider pregnancy to be the most sensitive and the most delicate and the most amazing determinant of where we have to provide safety and insight. And so when you can say that this is safe during all phases of pregnancy, that really is a huge stamp of safety for everybody and everything else under all other circumstances. So I think that the answer is yes, and it speaks greatly to how safe this vaccine is.
So the benefits outweigh the risks, for sure.
By a large
And the
large
vaccine
margin.
does not change the DNA of an individual.
No, it does not.
Karen?
Yes.
Make a quick comment on what was just stated.
Yes, Dr. Brooks.
I think the question I didn't answer was this vaccine came to market fast. So Dr. Fobbs addressed some of that. The main way it came to the market so fast is that the government gave up to $25 billion with a B dollars to allow the manufacturers to make it while they were developing it. So in other words, suppose you made it and it didn't work, you would throw away $2 billion worth of production. The government said, you can do that. We'll give you the money. So that's probably the most significant aspect of how it came to be in so fast. Phase 1, 2, and 3 studies all did occur. But I just want, because I think that's one of the primary concerns out there in the community. So we looked at that and we understand how it came to the market so fast.
So we should
And we can't wait.
Right.
Couldn't wait 2 or 3 years. Be another 3 million people dead. So I'm
Exactly.
sorry, that's just the way it is.
Exactly. So we should not have fears or concerns that the vaccine seemingly was created quickly. We had the technology, all of the studies were done, and we had the monies available to make this happen. And I agree with you. Thank God it's not taking 2 and 3 years for the vaccine, because we would be losing people at a greater rates than what we already are. So, Dr. Brooks, the Pfizer vaccine, if I'm correct, it is approved for those that are 16 years of age and older?
Correct.
And the Moderna is for those that are 18 years and older?
Correct.
Can you speak to the refrigeration? Because what I'm thinking is that the clinic settings, there were underserved populations who don't have the capacity to have those refrigeration units to keep the Pfizer on hand. They probably will receive the Mrna vaccines. Is that kind of what's happening?
Yes.
Yes.
Very good and very insightful. The bottom line is this. Pfizer has to be kept at minus 94 degrees Fahrenheit until you thaw it. Now, once you thaw it, it's good for, you get it, it's going to get it to freezing. I'll probably get it from minus 94 to minus 5. So after that, it lasts for 30 days. So if you get Pfizer, it comes in a box where if you put dry ice in it, it'll last you for 30 to 35 days. So even if you don't have an ultra low freezer, you can get a Pfizer and it'll last 30 to 35 days. Moderna, okay, we're getting it at my health center now. We're getting Moderna. It's coming at refrigerated temperature, which it lasts 30 days. If it's frozen, it'll last 6 months. So these are technical things, but for the public that's out there, trust us to do the right thing. And if you walk in, you can ask which one we have, but the answer is, are you going to get it? The answer is yes, I'll take Moderna. Yes, I'll take Pfizer. Okay?
Yes. Now, are any of the clinics receiving both vaccines? The reason I'm asking is if I am, say a mother has a 16 and 17-year-old at the clinic, and the only vaccine that is available is the Mrna, which should be given to those that are 18 and older, that 16 and 17-year-old that came in to get their vaccination will not receive it that day. Is that correct?
Well, right now, they wouldn't receive it anyway because it's not recommended unless they're a healthcare worker. So we're going through the tiers of the allocation. But the answer is yes. If you only have Moderna, they cannot get it until they're 18.
Yes.
That's what the FDA approved, and that's what I follow.
Thank you. Now, as information on COVID-19 disease is shared daily, there has been mention of the spike protein within the virus. Dr. Carter, please offer more information about this protein that seems to confer disease, but also aids to prevent symptomatic disease once an individual chooses to receive the vaccine.
I actually would like him to start because I think he'd do a better job to fill in the blanks.
All right, so real briefly, the spike protein is how the virus enters the cell. So it's what makes the virus, part of what makes the virus so deadly. It hits certain sites in our body, angiotensin ACE inhibitor, ACE sites. What happens, therefore, if you make an antibody, so just think about here's this spike going into the cell. If you make an antibody that blocks that spike, then it can't enter the cell. So the relevance is that you make an antibody against the part of the virus that's deadly. So that's basically what's happening. And I believe that with these variations, the new strains like in the UK and what you're hearing, I believe is what's happening is that variations are not changing overtly the spike protein, which is what, but it's like, it's the knife. So even though, the handle of the knife may be changing, the blade of the knife isn't. So the vaccines, we believe, and we don't know for sure, are working against these new variants that are now spreading.
Okay, thank you.
Karen, can I add something to that?
Please,
because that's an important point that Dr. Brooks just made.
Thank you.
One of the things that the public needs to understand is there's a lot of question about these two vaccines. They're mRNA vaccines. Think of a computer. It works because we write code for the computer, all right? There's no better computer than this computer that God made, the human body, all right? So all of our cells have codes, and that's what the RNA and the DNA part that we always talk about is referring to. These two vaccines being mRNA vaccines, when we get them, it teaches our cells how to recognize the spike. So then we develop the antibodies ourselves, and the spike is then neutralized so that the virus cannot enter our cells. And that's what's going to keep us safe. They don't contain the virus, so that you never get sick because you never get the virus. You get the ability to recognize it. And that's what's important for people to understand, so that we can take away the fear about taking these vaccines.
So by getting the vaccine, our body will rear up an antibody response, which is kind of like an inner army to fight this thing when it hits us, which again is that antibody response. So when we get the vaccine, we know one thing: we're not being given the disease, but when you get the vaccine, you're giving your body an opportunity to create antibodies, and those antibodies will protect you, reduce your rate of getting symptomatic COVID-19 disease by 95%. And if you have those other comorbid conditions, which we'll talk about later, that's like, I mean, that is amazing, because if you are going to the hospital and you already have high blood pressure, high cholesterol, diabetes, dyslipidemia, or high cholesterol, as I said, you're not starting at the line, you're starting back here. So you got to take care of all of that in addition to COVID-19, and that's why, in addition, it's so deadly. Now, Dr. Wiley, when seeing patients, when I see patients, I've been asked about several conspiracy theories that have been swirling about on social media platforms, such as by receiving the vaccine, an individual's DNA is changed, or the vaccine contains an ingredient that can track an individual's whereabouts, so forth and so on. Is there any truth to these theories? And as I mentioned, I won't have you answer the second portion, where does the vaccine work within the body? We just kind of went over that. But is there any truth to these conspiracy theories?
No, I can categorically say that all these conspiracy theories are wrong. And you can find anything on the internet, and that's where all these emanate from. If you want to know the facts about this virus, I would recommend the CDC's website. They go over everything. These are vetted by scientists, and the information there is accurate and true. These are just theories that people find out there on the internet that swirl around. And again, if you repeat something so many times, people seem to believe it. They are not true, and there is no virus in the vaccine, and there are no microchips in the vaccine. And so these are theories from the internet, and they are false.
And I think because the vaccine works on the outer area of the cell, it does not penetrate into the nucleus, or where the DNA is, if you will. So, Dr. Egerton, there are certain preventative and precautionary measures that we as a community can take to help reduce the spread of COVID-19 disease. Please explain what the preventative measures are and elaborate as to why these precautions must be taken seriously.
Well, there's nothing new here. These are the things that we've been saying since the start of the pandemic. The chief preventative measure is physical or social distancing, staying away from people who may be infected, or if you have to go out, maintaining a distance of at least 6 feet between you and someone else. The second is this. I cannot emphasize more strongly the need to wear a mask. Masking protects you. It's a way to minimize the chance that you'll spread the disease by inadvertently, and also that someone will spread it to you if you do tend to come in contact with them. Obviously, if you're not spending more than 15 minutes with someone, then your likelihood of getting the disease is lower. The third is hand washing, hand hygiene. So, the use of soap and water, hand sanitizer as often as you can, particularly if you're out and handling items, if you have to go to the store to get some food or go to the drugstore to get some medication, hand hygiene. My wife is vigilant about that. As soon as I get back in the car, she's got the bottle out there for me, and I'm doing my hands. I mean, as a physician, I have to wash my hands a lot anyway, in between patients or in between contacts, or if I'm coming on or off the ward. So those are the three most basic things and nothing is going to supersede that. With the advent of this vaccine, I think we have a very powerful preventative measure. If we can get enough people to take the vaccine, then we can better and more quickly achieve enough immunity in the population as a whole, what we call the herd immunity, so that we can get to the other side of this pandemic.
Thank you. You mentioned, yes, Dr. Fobbs.
I just want to add a point to that. Actually, Dr. Egerton stimulated me to think about this when he was talking about the inflammatory response. And since we're in a church environment, it probably is appropriate to say that there are some preventive measures that go before the ones we specifically annotated so well about the virus specifically. One of those and it has to do with stress. Stress contaminates and diminishes the immune system. And I'm surrounded by pastors here, and I'm not going to even attempt to quote the passage of the verse, but I did go to Morehouse though. And so I know something about Dr. King and his family. And so I can say that somewhere I read that there is a peace given by the Christ who we believe in, that was given, that surpasses understanding, that is designed to diminish and release and absolve one of stress. So if that is practiced and done diligently, then we can do something about stress. And the other thing is that somewhere else I read that there are things that are given that grow from the ground, the bush, the trees, and we should expect those to be healing things. And a couple of those are mentioned in the Bible, and a couple of them you can go to your grocery store or to your your vitamin shop, and a couple of them that are anti-inflammatory, speaking to what Dr. Egerton was pointing out as being such a serious matter, and also mentioned by Dr. Wiley, and is the combination of things like turmeric and curcumin, and this thing that everybody in the church knows about called boswellia, better known as frankincense, are magnificent anti-inflammatory things that you can just take and have on board all the time, so that if you do get something, you're more likely to not die from it or get very sick from it. So those are just things that we also should be taking into consideration.
So reducing our stress and building our immunity and following the guidelines of the CDC. Now, washing your hands often, wearing a face mask, the vaccine administration, I'm all for that. Limit your exposure, social distancing, staying home if you're ill, clean and disinfect, especially frequently touched objects. And if you suspect that you have COVID-19 disease, call ahead before visiting your doctor. Now, there is more information available on the CDC website. Now, millions of individuals, Dr. Brooks, millions of individuals have had to quarantine in their private residence where others also reside. That must be challenging. Please define what it means to quarantine and how that should be structured in a shared household.
Quarantining is when you have been exposed. So you are really good at having those definitions at the beginning. So I think it's important for people to understand that. Isolation is when you have the condition, and therefore you isolate yourself from others. So you need to wear a mask, you need to keep 6 feet away. This is quarantine, as if you were exposed. You have to not share utensils. You have to eat off of different plates. Obviously, sleep in different rooms. This is one of the reasons why African Americans have more challenge. We have 5 people in a 2-bedroom apartment versus 2 people in a 6-bedroom luxury home, which others may have. So that is what you need to do. You need to keep your distance. You need to not share utensilary and foods. You need to wipe surfaces down. And again, maintain your distance. And I would say, honestly, that's somewhat of a challenge. So the most important part of it, quite frankly, another W, the W's are wear your mask, wash your hands, and watch your distance. The fourth one to me is wait, or be patient. So generally you quarantine for 10 days. So that's going to be a long 10 days for you. But if you don't like that, you really won't like being on a ventilator. So really just mark on the calendar, 9-8-7-6, 1 day left. And actually, one other thing of interest, the quarantine was 14 days, but in the last month, maybe 3 weeks, the CDC cut it from 14 to 10, 95 versus 92% efficacy. So 92% is okay. Just one little addition in terms of treatment, and I'd be curious if any of the other physicians endorse this, but vitamin D, because African Americans are generally low on vitamin D because our skin is darker, and in the wintertime, we get less sunlight, 5,000 units a day, check your level. And then vitamin C, antiviral, vitamin C supports the immune system, vitamin D, and there are numerous studies on vitamin D. And then there are also studies regarding zinc. I will throw that out there for discussion. I personally do that. I think there's enough evidence, scientific evidence and lack of side effect profile. Those are easy things that the community can do to have a better immune system and better overall health.
I'd like to echo Dr. Brooks. In addition to that regimen with vitamin C, D, and zinc, I like to add melatonin as well, because a lot of our patients who've come down with COVID have had insomnia as one of the more pervasive symptoms that persists even beyond once the virus and the fevers have subsided. They're still suffering from that insomnia, and melatonin between 6 to 9 milligrams at night does help to improve that symptom specifically as well.
So thank you.
And the only thing I'd add with the vitamin D is that the recommendation is a loading dose, and then there's a daily dose thereafter. And to be careful about the loading dose, because you can do too much vitamin D, and that wouldn't be good.
Yes, thank you. Now, it is evident that COVID-19 disease is a pandemic that has killed millions of people. The vaccine seems to offer hope for individuals who choose to receive it. It might be fair to say that the benefits that the vaccine give outweigh the risks of COVID-19 disease without vaccination. Now, as trusted Black healthcare providers, this question is for all of you who serve all patients across the continuum. I have one final question for each of you. Have any of you received the vaccine or plan to do so when it is available? And I'll start with Dr. Fobbs.
Okay, I'm happy to respond to that, and I'm going to frame it in the framework of I think an old joke that everybody's probably heard, but that when a naked man offers you the shirt off his back, you should be leery of that. So it's the same thing if you have a bunch of doctors and healthcare people telling you should get a vaccine, but they won't take it, you should be leery of that. So I'm happy to say I've taken it, and I'll be getting my second shot on Monday. And I think that most people in America know, and I think they should take heed and hearten to the fact that President Biden has taken it, Vice President Kamala Harris has taken it, and all the people at the top of the CDC and the people you see on TV every day, they've taken it, and most of them have done this publicly. And so this is not like something that people are saying, you go do this, but I'm not doing it. It's just the opposite. They're telling you to do this, but while you're thinking about it, I've already got mine. So they should be aware of the fact that this is, I can't think of any greater support for something that all the people telling you to do it have already done it. Yeah.
Dr. Brooks,
I have Dr. Fobbs beat by 3 days.
Okay.
He got Pfizer because I got my second dose.
All right, all right. I'm trying to catch up.
I also, he failed to mention Anthony Fauci got vaccinated.
Sure.
So I absolutely got it. And one thing I want to add, I had a feeling of exultation. I didn't expect that. It was a true psychological high when I got the first one. The second one was like affirmation. I really did. And so I clearly believe in it. I don't want COVID, okay? There's a risk with the vaccine, which I believe is very minimal. I compare that to the risk of COVID-19. I think people need to understand the risk of COVID-19 can be problems for the rest of your life. You can survive the acute phase, but you can have all kind of issues months and years later. I'm vaccinated. I'm happy to say so.
Yes, I have received the vaccine. I'm waiting for my second dose. And, I encourage everyone to get the vaccine. The body is a wonderful biologic system. You will produce your own antibodies, but this vaccine will help spur that along so that you are not vulnerable to getting this horrific disease.
Yesterday as well. So we beat Dr. Favre, both of us. But the other thing that I want to put out there is even with my vaccine and second dose of vaccine, I will still continue to wear my mask, and you should too. Again, this is to protect you as well as everybody else. My second dose of vaccine was administered, but it still takes a couple weeks for the antibodies to develop. And that's another very important point that I want to illuminate for the public. Even though you're vaccinated, it takes some time for those antibodies to develop. So give it the time and continue to wear your masks. Thank you.
Dr. Carter speaks truth, and I would echo that. I am proud to say that I received my first dose. I got the Pfizer vaccine. I didn't even feel it, which I found strange because I thought it had been faked out, but I did get it. I'll get my second dose on Monday. The only side effect I had was the next day I felt the site of the injection, and that was gone in 24 hours. Nothing, absolutely nothing else. And it's important to note, there's always questions about, is this vaccine, is it done in eggs? Does it have, was it cultured in humans? These vaccines were not cultured in eggs. They do not contain stem cells. They are exceedingly safe to take, and I would highly recommend that everybody do that, but continue to wear your mask.
Thank you. At this time, I would like to thank our esteemed physician panel, who are some of the most trusted voices on this matter. Your input has been invaluable. Now, please allow me to recap several key points. The immediate numbers are and have been worrisome for communities globally and nationwide. People are dying in record numbers. In the United States, there are 21 million people that are positive, and over 370,000 have died. I assure you that as I am standing here, the numbers have already increased. I am all but begging you to take this pandemic seriously. Because COVID-19 restrictions, this platform for dispersing credible information is key. We are attempting to reach you where you are and to let you know that we care. We understand that the hesitancy to receive the vaccine is real. We understand that there is a legacy of mistrust by the Black community, of the medical community, based on the exploitation, the abuse, and the experimentation on Black bodies in history, and even today. That cannot be denied, and we are not denying that. However, we should not become infuriated by the process of vaccine rollout or somehow think that we are immune to contracting COVID-19 disease. If anything, as Black people, we are at greater risk. Instead, engage and make a difference for generations to come. Now, the social determinants of health, the places where we live, work, and play, have adversely affected the well-being of Black people. The data also indicates that the disparities of health and the weathering effect, stress amongst Black people, places us at greater risk of death, in part secondary to comorbid conditions such as high blood pressure, diabetes, kidney disease, and high cholesterol. These conditions can lead to stroke, heart attack, and organ failure. Need I say, along with COVID-19 disease, our risk of death increases drastically. We have an opportunity to contribute to our own wellness, the wellness of our families and the community. We have a seat at the table, and we must be responsible. Our Black physicians today are allowing you to see who they are, hear their voices, and know their concern. They believe in the information that they have shared. All 5 of our panelists have taken the vaccine. When I think of individuals dying alone, counties throughout the United States having to order 5,000 body bags at a time while renting refrigerated trucks to hold the bodies of our deceased loved ones, it saddens my heart. Ambulance vehicles are waiting outside of emergency rooms with sick individuals in the ambulance because there's no space inside of the ER for the individual. I recently read that a gentleman was in an ambulance for 19 hours before being allowed into the ER, and he was presenting with stroke symptoms, not COVID-19, stroke symptoms. The rearranging of hospital chapels and gift shops into makeshift patient rooms is alarming. America, BIPOC, we must become proactive and take this pandemic seriously because it is further threatening the health and legacy of our people. All of those working on the front lines are being pushed to their limits. They are exhausted. For you and I, they put on their armor day after day, often quarantining away from their family, sacrificing their family time, working extra shifts, long shifts. And by doing so, as Pastor McGenzie said, they are risking their own lives. Have you given thought how many people would die if our healthcare providers are unable to do their jobs? We must become a part of the solution. To the frontline workers and the management teams, thank you, and we are pleased that your teams are first in line to receive the COVID-19 vaccine. The statistical evidence regarding the Mrna and Pfizer vaccines are similar in their efficacy. They do what they are meant to do, which is to confer approximately 95% reduction in symptomatic COVID-19 disease for individuals who choose to receive the vaccine. In dispelling a couple of myths, receiving the vaccine does not give you COVID-19 disease, nor does it change your DNA. You will remain fearfully and wonderfully made. Now, on a national level, a special thank you to Dr. Kesmakia Corbett, a Black female physician who is a viral immunologist who served as a lead researcher and team member in the development of the Mrna vaccine. She stands by the effectiveness of the vaccine. In closing, the COVID-19 vaccine is available. We hope that this town hall meeting has offered you the necessary information that supports your decision to receive the COVID-19 vaccine. We must work together to save lives and slow this contagious virus, SARS-CoV-2, which causes COVID-19 disease, by following the guidelines as recommended by the Centers for Disease Control. Please follow the science and consult your doctor regarding the vaccine, your risk factors, and your overall health. Bless you, and thank you for your time.
The African American Coalition encourages our community members to get tested. And guess what? If you test positive, you're not alone. We are here to support you every step of the way. We will help you through education, isolation, quarantine, financial support. So that means if you need help paying your mortgage, your rent, your PG&E bill, we're here to support you. If you need help with food, cleaning supplies, access to mental health support, for example, and more, the African American Coalition is here to support you. So I want to thank again our pastors and our physicians on this panel today who have provided their clinical and pastoral expertise to our community to help understand what's happening in the community in terms of COVID-19. And I'm also honored to come as a public health expert to bring you real-time information about how we can help you, how the Black community really is structuring, how we're convening, how we're coming together to make sure that in the Black community, we have support to help folks that need it. And so the public health message is, please continue to social distance. Please continue to wear your mask. Please continue to stay within your own household, right? In the Black community, it's very normal for us to sort of get together with our aunts and our grandparents and our cousins and our sisters and our brothers. And we need to remember that right now we are in a pandemic and the spread is rampant and it's impacting us. And we need to stay within our own homes. We need to not congregate. We need to not come together. We need to find alternative ways, right, that we engage, such as Zoom or such as this public health message, right, that Family Community Church, our leader, Pastor McGinsey, has put together. And it's okay for us to congregate in a different way because we're in a pandemic. And so as a public health advocate, as a person living in the county of Fresno, as a Black woman who's doing this work, I want to say thank you to everyone. Thank you to everyone, all of our leaders, all of our community members who are listening, who are paying attention, who are doing what they can to decrease the spread of COVID-19 in our community. We need you. We need you every step of the way. So thank you. So with that, I want to say again, the African American Coalition is here to serve you. The African American Coalition is here to serve the community. If you test positive, again, you're not alone. We are here to support you. So for more information, please visit the AfricanAmericanCoalition.org. Again, AfricanAmericanCoalition.org. We are here to support you every step of the way. Happy 2021. Let's beat this together by following the public health protocols, by masking up, by practicing social distancing, by not congregating in our households, by getting tested if we have symptoms, and by using science and evidence-based information around the COVID vaccine and COVID testing.
Lewis, and saying thank you to all the physicians and the pastors and Dr. Brooks as well, by way of Zoom. I want to just take a moment and go to Dr. Fobbs just for a second. It's my understanding you're part of the National Medical Association. Can you just share a little bit about the background of the National Medical Association? And then maybe you want to share with Pastor Brooks, do they hold a certain position regarding the vaccines for COVID-19?
I'm going to very happily defer that question to Dr. Brooks because he is the immediate past president of the National Medical Association. So why don't you go ahead and respond?
Well, thank you, Dr. Fobbs and Reverend Dr. McGinsey. So the National Medical Association was formed in 1895 because we were unable to get on staff at hospitals. We just noted basically apartheid as it relates to medical care for African Americans. So we are 125 plus one, I guess now, 126 years in existence. We represent the nation's 55,000 African American physicians. In August of 2020, our governing body met and they passed a resolution. The NMA developed a task force to look at COVID-19 or SARS-CoV-2 treatments, including vaccines. On December 21st, after meeting with Pfizer, AstraZeneca, Mrna, we met with Janssen, J&J yesterday. We meet with their top scientists by ourselves, just us. On December 21st, we released a statement stating that we affirm and endorse the use of Mrna and Pfizer vaccine. Those are the only two that have been approved by the FDA. So the National Medical Association, after vigorous review directly with the corporations and looking at all the scientific data, including meeting with the FDA and the ACIP, the CDC endorsed both vaccines as safe and effective in the African American community.
Thank you very much. Pastor Wilson, just a final question for all the pastors, but with you speaking for them. We realize everyone processes information a little differently based on their life experience. And I just want you just to take a moment and talk to that mom, that single mom, that grandmother that may be raising children. And she may not have anyone to converse with about whether or not they should take this vaccine or not. She may not have a family physician. She just goes to the emergency care when she needs medical care. What do you say to her regarding this vaccine?
Thank you, Dr. McGinsey. I would say to the individual that you're describing, with their faith and trust in Christ, who is the Spirit of truth, that she can be well assured that the Spirit of God will never lead her to where life would deceive her, and that when she prays and as she seeks direction from God, God will speak. And if she has a pastor, a local pastor who may be watching, this is a great opportunity for us to rally the saints, to encourage them, and to use our pulpits and any teaching platforms that we have to encourage and equip them to make the proper decisions that they need in order to sustain life on this side.
Thank you very much. Pastor Blackwood is going to come now with a closing prayer. And once again, I just want to thank each and every one of you. I want to give you a hand clap of encouragement.